Assalamualaikum. Assalamualaikum warahmatullahi wabarakatuh. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. Thank you, Ms. Chairperson. So today I'll talk on the topic of beyond the notes. So from this topic alone, rasa ramai dah boleh agak apa topik yang saya akan perkatakan. When we talk about notes, tak ada benda lain lah, lymphoma, right? Okay. Alright, a few agenda from this talk is I want to talk about a little bit about hematological malignancy. There's a few hematological malignancy, some awareness about this. I'm sharing a few cases, 4 cases on how this lymphoma can be presented. A little bit on introductions of lymphoma, and the key points of this talk is about primary extranodal lymphoma, and we'll end this talk with some take-home message. Alright, what is hematological malignancy? So when you refer a case to hemato, definitely will ask for possible hematological malignancy. So hematological malignancy, there's a lot, but commonly named as a leukemia, lymphoma, multiple myeloma, myelodysplastic syndrome, as well as myeloproliferative neoplasm. And all these are actually malignancy. It's a cancer. So leukemia common it can be acute or chronic, and this is a quite easily been identified when patient presented with cytopenia, bleeding tendency, fever, lethargic, and anemic symptoms. And leukemia can be acute and chronic. Lymphoma, this is our main topic today. It can be indolent, it can be aggressive, and it can be very aggressive. But we have more than 7 subtypes of lymphoma with different histological subtypes as well as different treatment approach. Multiple myeloma, this is commonly presented to nephrotim with renal impairment. They also commonly presented to orthopedic team with pathological fracture, chronic lower back pain. Alright, this is also a hematological malignancy. Myelodysplastic syndrome, previously been known as a pre-cancer state, but it's actually a cancer, commonly presented with pancytopenia, leukopenia, or even single lineage thrombocytopenia. Myeloproliferative neoplasm, this is sometimes been misunderstanding, not a cancer, it's actually a cancer. Polycythemia vera, essential thrombocytosis, as well as primary myelofibrosis. But in layman words, this is still cancer darah putih. Alright. Last year, we have been highlighted when our celebrity chef, Chef Wan, been diagnosed with cancer lymphoma. So he shared everything. So they share semua benda, including how he has been diagnosed with lymphoma when he presented with some small lymphadenopathy over the cervical lymph nodes. He shared everything, including how the diagnosis has been made. He shared how positively he underwent this cancer treatment, and this also include how much it costs for him to complete 4 cycles of chemotherapy, of course at private setting. Alright, this is not new. A few years later, before, other celebrity also been diagnosed with lymphoma, and they successfully been treated and completed treatment. So this might make my life sometimes easier when you refer a case for possible lymphoma before we start the counselling. Patient akan tanya, sama dengan Chef Wan tak diagnosis ni? So it's a little bit easy as a starter, but their expectation is much more than before, right? Not only humans, the ones of the hero in Batangkali landslide also been diagnosed with lymphoma. Unfortunately, he lost a battle due to advanced stage. So what is actually lymphoma? Lymphoma is a group of disease caused by malignant lymphocyte. So lymphocyte is our blood cell, and it's commonly presented with lymphadenopathy. And the one with aggressive lymphoma will have these B symptoms, namely fever, drenching night sweats, or unintentionally weight loss of 10% or more within 6 months of the diagnosis. So as you know, these B symptoms is almost the same with the symptoms of tuberculosis. So this explains why most of our lymphoma patients, when they presented to other primary healthcare or other specialty, they've been worked out for this tuberculosis, sometimes a few times before the diagnosis of lymphoma been made. And there are more than 70 subtypes of lymphoma. So from this KKM leaflet, you can easily know what is the symptoms of lymphoma. Is it the lymphadenopathy, hepatosplenomegaly, prolonged fever, demam berpanjangan, loss of appetite, loss of weight, lethargic or malaise. And what I want to highlight here is that ruam dan kegatalan kulit, the pruritus. So we notice that our patient, when being referred to us, the first thing that I will ask is about history of pruritus. This is something quite striking. As much as 40% of patient will have this preceded history of pruritus. So dah 1 tahun dia ada gatal, unexplained itchiness. So that's quite suggestive of lymphoma rather than other cancer. So who are at risk of being diagnosed with lymphoma? Usually the patient akan tanya, apa risiko saya dapat lymphoma ni? Why I've been diagnosed with lymphoma? How can I get this lymphoma? Commonly, a few chronic infections, especially HIV, EBV infections, H. pylori infections, hepatitis B and C are at risk of developing this lymphoma. And those who have autoimmune conditions and those who have penyakit keturunan like atasic telangiectasia also at risk of developing this lymphoma. But most of the time, we couldn't find the cause of lymphoma. All right. So how common is this cancer? So lymphoma is actually the fourth commonest cancer in Malaysia. This is based on our Malaysia National Cancer Registry Report 2012 to 2016. It's almost the same from the previous report. And if you want to compare between male and female, it's still within top 10 of commonest cancer in Malaysia. So in general, diagnosis of lymphoma require excision biopsy. So excision biopsy is the gold standard tissue biopsy of lymphoma. It's not FNAC, it's not core biopsy. Why? Because lymphoma full architecture of the lymph nodes, because it will give different histological subtypes, which will further give different treatment approach. Staging wise, we still depends on the CT scan, but the latest guideline is we have to use this PET scan. Unfortunately, we don't have it here in the East Coast region. Treatment wise, in general, still radiotherapy and chemotherapy. And in selected cases, especially limited stage 1 and 2 radiotherapy radiotherapy monotherapy can be one of the treatment modalities. Right. So prognosis wise is not based on stage. So that I always tell my MO that even though the patient been diagnosed stage 4 disease, don't give up. Because in lymphoma, there's other prognostic marker that we are using. We are not using the stage of the disease itself. It depends on age, the abnormal LDH at presentation, the performance status, how much the extranodal sites involved, as well as the stage 3 and 4. So as you can see, even with the 4 or 5 risk factor, the 3-year progression-free survival and 3 years overall survival is still more than 50%, and that's quite good for cancer cases. Right. Unfortunately, not all lymphoma presented with lymphadenopathy. Right. This is sometimes the diagnosis being delayed. So we expect kalau being referred as lymphoma, there will be some lymphadenopathy, kebengkakan kelenjar limfa. Right. So here I'm sharing a few cases of which how the lymphoma can be presented other than lymphadenopathy. So we start with the first case. This case presented to orthopedic team. 39 years old man, active smoker, not no medical illness before. He presented with lower limb weakness, bilateral lower limb weakness, also having upper back pain. He denied of having any history of trauma, and he needs a walking stick to walk. Clinically, upper motor neuron lesions of lower limb weakness, and LDH representation was 346. And the MRI done, this is a lumbar spine MRI. You can see there's afflicting lesions over the L4, causing compression to the spinal cord. The MRI, thoracic and cervical also showed some paravertebral soft tissue mass, with involvement of T4 as well as T11, causing the spinal cord compressions and edema. So he underwent decompression T3, T4, and posterior instrumentations, and the right axillary lymph nodes biopsy taken at the same setting confirmed the diagnosis of diffuse large B-cell lymphoma, and the bone biopsy taken during the procedure also confirmed the marrow infiltrations. So we concluded him as stage 4 disease. So this is a quite rare presentation, but we encountered a few cases with presented to orthopedic team with spinal mass, which confirmed the diagnosis of lymphoma. So he started chemotherapy 2 weeks, as soon as 2 weeks after the operations, of which we gave him 6 cycles of R-CHOP chemotherapy with high-dose methotrexate. And Alhamdulillah, by end of the treatments, his PET scan shows complete metabolic response. So complete metabolic response in cancer can be considered as remissions. It is not actually equal to cured, but at that particular setting, you can consider it's cured at that particular settings. So how about the patients? He underwent rehabilitation. He in fact was sent to Malacca for rehabilitation under Perkeso, and Alhamdulillah, is now ambulating well, unaided and back to work. All right, one successful story. Second, vaginal lymphoma. This one presented to our gynae colleague. 56 years old, nulliparous, menopause 6 years ago, presented with vaginal swelling for 1 year before short treatment. It was associated with a vaginal discharge. Clinically, there's no lymphadenopathy or organomegaly, only hard mass over the right labia majora with a contact reading. Ultrasound revealed mass in the vagina extending to pelvic, measuring 8 times 10 centimeter, and the biopsy taken confirmed the diagnosis of diffuse large B-cell lymphoma. So as you can see, the LDH also high, 416, and the CT staging at diagnosis show extensive local infiltrations with rectovaginal fistula and cross right hydronephrosis and hydroureter. So she underwent trifine transverse colostomy, and we started her with chemotherapy about 3 weeks later with R-CHOP chemotherapy. Her journey quite long. It started in August 2022 when we start with first R-CHOP chemotherapy, and she completed the chemotherapy in November. Some complication with neutropenic sepsis, but Alhamdulillah able to complete full 6 cycle of chemotherapy. Unfortunately, end of treatment PET scan shows small volume FDG-avid active lymphoma in the vagina extending to pelvic. So we subjected her for another sessions of radiotherapy. She underwent 28 sessions of radiotherapy in SUSM under oncology team. Alhamdulillah, last year, she achieved complete metabolic response. All right. So another successful story. Third case, marrow lymphoma. So this is a quite uncommon cases of which we only encounter about 1 or 2 cases per year. This unfortunate lady, 45 years old Malay lady, not no medical illness, presented with prolonged fever and lethargy associated with loss of appetite. So she had visited GP for 2 times and was discharged with gastritis medications, and giving the history of recent fogging at residential areas, so she has been worked up for possible dengue as well. Clinically, there's no lymphadenopathy, there's no organomegaly. Dengue contest shows IgG and IgM positive, but the white cells leukocytosis with mild anemia and thrombocytopenia. She was treated for sepsis and intubated on day 4 due to worsening lactic acidosis. So issue with this patient is that she had persistent fever despite of one week admissions. The fever persists and with a negative culture. So LDH at presentation was 12,000, quite high. and she was referred to us for leukocytosis and pancytopenia. With the full blood picture on, he shows some reactive lymphocyte. So we proceed with bone marrow examinations on 40th of December, and we received the preliminary result a day after, and this is actually Burkitt lymphoma. You can see the trifine bone marrow being infiltrated, all been infiltrated with this lymphoma. So Burkitt lymphoma is the most aggressive form of lymphoma, and in fact is the most aggressive form of human malignancy, with a rapid doubling times, acute onset, and progressions of symptoms. Unfortunately, these patients succumb to death 5 days after the treatment being started due to neutropenic sepsis and shock. So this patient passed away. Last case, primary mediastinal B-cell lymphoma. This is quite common, referred to us. 27 years old Malay man, a police officer, just started training in Tawau. He presented with sudden onset of left-sided chest pain and worsening shortness of breath, preceded with a month of prolonged cough and hoarseness of voice. So of course, he has been woke up for PTB 3 times, and because of he has a loss of appetite and loss of weight, diagnosis of malignancy was as one of the differential diagnosis at presentations. So as you can see, chest X-ray shows huge mediastinal mass with some left pleural effusions. Clinically, he had SVCO, superior venous cava obstruction signs, which is the standard neck vein. And again, there's no lymphadenopathy, no hepatosplenomegaly, and the LDH at diagnosis was 695. You proceed with CT thorax, it shows huge anterior mediastinal mass. You imagine about 9 times 15 times 13.1 cm, about football punya kan, bola sepak, in the mediastinum of the patients, with local mass effect and partial superior venous obstructions. So ultrasound guided biopsy done by our radio team confirmed the diagnosis of primary mediastinal B-cell lymphoma, and he received 6 cycles of rituximab dose-adjusted EPOS chemotherapy, and Alhamdulillah, he achieved complete metabolic response and going back to training to become a police officer. So this is another successful story. Primary mediastinal B-cell lymphoma, when hematology team being referred for possible lymphoma in a patient with huge mediastinal mass, I'm praying hard this is PNBCL. Why? It is highly curable among other types of lymphoma, with event-free survival and 5-year overall survival up to 97%. And it's typically occur among young female patients at their productive age, and more than 90% of patients will have this bulky mass. So what is the similarities from all those 4 cases is that they presented with not typical lymphoma symptoms. Some of them has lack of B symptoms. Kan kalau lymphoma semua akan tahu, doktor ini akan tanya B symptom. What is B symptoms? Fever, loss of appetite, loss of weight, drenching night sweat. But from these 4 cases, not all of them presented with B symptoms, and lymphadenopathy was not prominent or even not present at the time of presentations. And they presented to other subspecialties first, except if there is involved cytopenia or marrow lymphoma. And for marrow lymphoma, fever can be the only signs and symptoms. Like our 3rd cases, she just presented with a prolonged fever, been investigated for a lot of different cause of infections until the diagnosis for marrow lymphoma being made from the bone marrow biopsy. Widened mediastinum with high LDH in young patients, diagnosis of primary mediastinal B-cell lymphoma should be considered. Alright. So this is what actually beyond the notes. Beyond the notes means that there's other subtypes of lymphoma that can present extranodally. 1/3 of lymphoma arise from sites other than the nodes, and the definitions of extranodal lymphoma is actually lymphoma with no or only minor nodal involvement associated with clinically dominant extranodal component. And it can originate in almost every organ. You just name it. It's from gastrointestinal tract, skin, bone, brain, heart, orbit. So the most common site is still GI and skin. Bone and brain also the most common site, but it depends on the geographical area of the diagnosis. So this is one of the comparisons between previous studies being done for this primary axonal lymphoma. As you can see, it's not so common, and it can involve a few sites, commonly GI, nasopharynx, head and neck, brain, intestine, aerodigestive orbit, bone, breast, testis, spleen, vulva, kidney, apa lagi? So in fact, we have a few case report on heart lymphoma, right? And histopathologically, commonly is diffuse large B-cell lymphoma, which is also the most common types of non-Hodgkin lymphoma. So how about in Malaysia? We don't have data on Malaysia, but we have our own local data. 2-year study done in HRPZ and Hospital Kuala Krai, which is two centers that treating this lymphoma. We have 49 primary extranodal lymphoma diagnosed within these 2 years, 2022 to 2023. It consists about 38% out of all 130 non-Hodgkin lymphoma with median age of 55 with slight female predominance. And unfortunately, majority of cases been diagnosed with stage 4 disease. Why? Because the presentation is quite rather different than any usual type of nodal lymphoma. And the mean LDH at diagnosis was 804. All right. So in terms of site, cutaneous or skin was the majority of the cases, followed by tonsil as well as nasopharynx. So this is an example of our cutaneous lymphoma. The first picture is our diffuse large B-cell lymphoma. Second picture is anaplastic large cell lymphoma. Third picture is peripheral T-cell lymphoma. And the fourth one is diffuse large B-cell lymphoma. So this is how the cutaneous lymphoma can be presented. It's quite nodular, scary looking, ugly looking, right? So histologically, same like the previous studies, diffuse large B-cell lymphoma is the main histological subtypes for this extranodal lymphoma. Prognosis-wise, it has inferior overall survival if compared to the primary nodal lymphoma, and the presentations of localized extranodal non-Hodgkin lymphoma is prognostic of clinical behavior and is an independent determinant of the outcome. So different subtypes of primary extranodal lymphoma has different outcome. Like I mentioned earlier, primary mediastinal lymphoma which is highly curable, while marrow lymphoma is most of the times has a poorer prognosis. All right. So I think, okay. So we end with some take-home message. So this is a simple presentation just to give an awareness about how the lymphoma been again presented, and so that you can give some information or awareness to your family members, or when you encounter cases with not just lymphadenopathy but unexplained prolonged fever, unexplained concessional symptoms with undifferentiated manifestations of lymphoma. So lymphoma can present without lymphadenopathy. That's first take-home message. And they can present it to other subspecialty. So other than your own common oncology cases from the gynae, orthopedic, surgery, ophtha, you should consider lymphoma as one of the differential diagnoses when the presentation is rather different from the other subtypes of oncology cases, and the LDH was high. Take the biopsy and review it early. But nowadays we receive a good collaboration with our pathology team when there's any lymphoma cases we've been highlighted earlier before the primary team been informed. And it is still treatable and curable if given earlier interventions, but unfortunately it can be dreadful if delayed in diagnosis. Even a simple chest X-ray for blood count, even though the lymphoma, the full blood count can be normal, but when there's presentations of cytopenia for blood picture is mandate, and LDH will help, and this help us a lot. Okay, And lymphoma still can be cured even with stage 4 disease. So don't be afraid. Don't give up it early. Even you have received a patient with a lymphoma, stage 4 disease, I still accept it as a referral to us as urgent because we can still change the prognosis if we able to give the treatments completely. All right, I think that's all. It's just a 2-minute presentation. So before we go to Q&A question, there's some quiz. Ada. First quiz, name one of the B symptoms. Okay, Rudy tak payah jawab. Ha? Fever. Okay, betul. What is the commonest extranodal lymphoma in Kelantan? Tak ingat. Siapa jawab skin? Amira. So cutaneous lymphoma is one of the commonest extranodal lymphoma in Kelantan so far based on our previous 2 years study. What is the most aggressive lymphoma? Burkitt lymphoma. All right, thank you.
Thank you, Dr. Anusha, for the very good and informative presentation. We now welcome any question or opinion from the members of the floor.
Ada.
Anyone? Okay, if there is no more question, I would like to
as part of your take-home message, any patient with abnormal weight loss, or should be investigated for cancer. Should already be significant, especially weight loss. That should be a take-home message.
Yeah. Unintentional weight loss. Kalau yang diet tu tak payah kan. So unintentional weight loss 10% within 6 months. That's a significant one. So any question? So it's quite a straightforward presentation just to give you an awareness about lymphoma and how the lymphoma can be presented with different manifestations. No more question. Good.
Any more question? Okay, if there is no more question, I would like to invite Dr. Anas Fahmi, Hospital Deputy Director 2, to deliver the certificate of appreciation to our respected today's CME presenter. Please welcome. Thank you, Doctor. With that, we have come to the end of today's CME session. The upcoming CME will be presented by Dr. Ahmad Tajuddin Fadiso from NS Department with the topic of the high-risk surgical patient role for a multidisciplinary team approach. Until then, thank you everyone. Assalamualaikum warahmatullahi wabarakatuh.